Hi, my name is Dr. Sophie Thorold. I'm going to be talking about the arterial blood gas. This gives an immediate reflection of the body's physiology, so it's good in admissions and the acutely deteriorating patient. To start, there are a few abbreviated terms used in an arterial blood gas. The pH is looking at the acidity or alkalinity of the blood, and it's determined by the concentration of hydrogen ions. So low is acidic and high is alkalotic. And the normal range is 7.35 and to 7.45. The scale is logarithmic, so small changes in the numbers, because that doesn't seem a wide gap, but it means big changes for the conditions in the body. PaCO2 and PaO2 is a measure of conduct and oxygen in the body. Bicarb is a buffer and makes up the majority of base excess. Therefore, you can normally interpret these values the same. As an overview, we want to look at the patient and then what do we want to find out? What do we want to rule out? So, are they receiving enough oxygen? Is the oxygen that we're giving to them getting to them in the right way? The PaO2 should be over 10 kilopascals in breathing air, and then about 10 kilopascals less than the percentage inspired concentration that you're giving them through the mask. So is the blood alkalotic or acidotic? And then is that caused by a respiratory component or a metabolic component? Carbon dioxide itself is an acid, so high concentrations create a more acidic environment, and low concentrations cause a more alkalotic environment. Looking at causes of respiratory acidosis, it's mostly caused by reasons that you wouldn't breathe off as much CO2. So obstructive causes, COPD and asthma, central nervous system, depression, opiates and head trauma, creating a reduced respiratory rate, obstructive sleep apnea, neuromuscular impairment, so reduced efficacy of breathing, so Guillain-Barré, obesity, myasthenia gravis, and deformities such as scoliosis. The body itself producing more CO2, so in vigor, seizures, malignant hypothermia, and iatrogenic causes if we've got the wrong ventilator setting or problems like that. Looking at respiratory alkalosis causes, it's because we're breathing too much. So we're breathing off too much CO2. So in a PE, if they're anxious or fearful. So because CO2 is an acid, it can be used to compensate for metabolic acidosis or alkalosis. With a metabolic acidosis, you want less CO2, so you might breathe faster to balance this out, and then the inverse with an alkalosis, you'll breathe more, you'll breathe less even, so that there's a build-up of CO2 to compensate and make the environment more acidic. Bicarb itself is a base, and so high concentrations create an alkalotic environment, and low concentrations create an acidic environment. Base excess usually mirrors bicarb, but gives a more comprehensive measurement. It rarely adds anything. Using these for values, you can get the anion gap, which is important in deciding the cause of a metabolic acidosis. So low would be caused by hypoalbuminemia or multiple myeloma. That's quite rare. Normal, a drop in bicarb, so gastro-related, maybe renal-related, sometimes in DKA and some toxins. High is, a way to remember this is mud piles, hence pigs. So methanol, uremia, DKA, paraldehyde, infection, lactic acidosis, ethylene glycol, and salicylates. And metabolic alkalosis is quite rare. It can be excessive vomiting, or so you're vomiting stomach acid up and then you lose that, or you're suctioning too much out of the stomach, or we're giving too much bicarb. As with respiratory compensating for metabolic acidosis or alkalosis, bicarb can be used to compensate for a respiratory acidosis or an alkalosis. It takes longer because it has to be created in the body, and it's not as simple as breathing faster or slower. So it won't be seen so much in acute problems, but in maybe chronic problems. So maybe COPD, you have a raised HCO to compensate. This slide gives an overview of all that we've discussed thus far. Again, this is another summary slide listing all the possible results. This slide looks at type 1 and type 2 respiratory failure. Type 1 is usually ventilation perfusion mismatch, so pneumonia or lung edema. Type 2 is maybe an asthma or an increase in area of the lung not available for gas exchange, so COPD, emphysema. Finally, I wanted to go through some other bits of the EBG that we haven't touched on so far. Glucose is important in DKA and sepsis. Lactate, again, is important in sepsis. It's part of the sepsis 6. You can check some other electrolytes this way, including potassium, sodium, chlorine, calcium. You can check the hemoglobin level. Notoriously, it's not accurate, so you'd always send one down to the labs with it, but it gives you a quick snapshot image, which might be helpful in an acute bleed. And you've got COHB, which is the carboxyhemoglobin, and so those will be high in smokers and people who have suffered comes dioxide poisoning. Thank you for listening. These are our references. This is a reminder to create your own concept maps for different symptoms and presentations to help your learning and your understanding.